Good morning or good afternoon. I am Valentin Fuster from New York, and we are in Paris at the European Congress of Cardiology of 2011. Here we have, as usual, an outstanding group, all professors, but it's a rather obsessive group, because rather than being in Paris enjoying life, here we are in a closed room discussing issues that should be discussed at a different time. So I'm sorry, but this is what we are. Anyway, I'm going to introduce each of them, and I'm going to start with my right, Professor Magnus Ohman at Duke University Medical Center, Associate Director of the Duke Heart Center. Professor Adnan Kastrati, Head of Catheterization Laboratory, Professor of Interventional in the German Heart Center in Munich. Mariell Jessup, of course also Professor, University of Pennsylvania, Medical Director of the Penn Heart and Vascular Center. And here in my left, I have Professor Bryan Williams from the University of Leicester, the United Kingdom. Next to you is Professor Silvia Priori, Leon Charney Division of Cardiology and Cardiovascular Genetics Program at the New York University School of Medicine, and Associate Professor at the University of Pavia. And finally, not the least, we have Professor Terje Pedersen from the University of Oslo, Director of the Center of Preventive Medicine. Well, thanks to everybody. This is going to be fun. Why? Because we have three studies which I think are outstanding that were presented in this meeting and are different from one to each other, but the three of them addressing critical questions. The first one is addressing atrial fibrillation with an oral 10A inhibitor. The second one is addressing the CETP enzyme of HDL. And the third one is maybe social economics, but don't worry, it's something else than the usual that we talk about. Basically, people are not taking medicines where you are in a high economy country or in a low economy country, and this is something we really have to discuss. So why we don't do this, let's go one by one, and what I will do as usual, I will summarize the study, and then we will have a discussion. Why we don't start with the so-called apixaban versus warfarin in patients with atrial fibrillation? As you know, atrial fibrillation has changed in terms of antithrombotic therapy. We have talked in the past about dabigatran, an oral antithrombin. Very recently, we discussed rivaroxaban, a 10A inhibitor, and today we are discussing apixaban. And results were quite interesting. Let's discuss first the study in itself, how it was designed. This is a randomized double-blind trial, which was presented by Dr. Christopher Granger as from the group at Duke, in which was compared apixaban at a dose of 5 milligrams twice a day with warfarin at an INR of 2 to 3. 18,000 patients with atrial fibrillation entered into the study, and they had at least an additional risk factor for a stroke. Now, the primary outcome was ischemic or hemorrhagic stroke or systemic embolism, and the trial was designed to test for non-inferiority, but the secondary objective was to test whether in fact was superiority, and in terms also of the rates of mesh bleeding and death from any cause. It is interesting, the study has has fascinating results, but it depends on the way you present the results. One can get very excited, moderately excited, or not too excited. So let me present the three ways that these results were presented. First of all, 1.8 years of follow-up and the results showed that apixaban was associated with 21% reduction in the risk of a stroke or systemic embolism, a 31% reduction in bleeding, and an 11% reduction in all-cause mortality. If you don't become excited about this, you have a problem. Now, let me present to you a second way. What I presented was relative results, absolute, and now I'm going to present this in absolute terms. A stroke or systemic embolism with apixaban 1.27% per year, with warfarin 1.6% per year. This is what before I talk about 21% reduction. Measure bleeding 2.1% per year with apixaban, with warfarin 3.1% per year. This is what I said was a 31% reduction. And the third one, all-cause mortality 3.52 versus 3.94, which is an 11% reduction. How important is to get a sense of relative reduction versus absolute reduction. However, all was very significant with superiority of apixaban over warfarin. There was only one issue that perhaps is worth mentioning, and that is ischemic stroke. There was no significant difference between the two groups. But I must say that looking at dabigatran and looking at apixaban in just together with rivaroxaban, this is the only drug that decreased mortality. So I like to present a third way of these results, and that is we have 1,000 patients treated for 1.8 years. In 6 patients, a stroke was prevented, 4 hemorrhagic strokes and 2 ischemic strokes. 15 patients out of the 1,000, bleeding was prevented, and out of 1,000, 8 patients, death was prevented. So this is basically the results of the study. I frankly think are very impressive. And now I like maybe to start with you, Magnus. Give us your gut reaction to the study.
Well, Valentin, as you, I'm very impressed with the results. I mean, these are very impressive reduction in all the major ischemic and bleeding events. So it's really an all-winner, so to speak. And then on top of that, you have total mortality that is reduced. Now, the thing about atrial fibrillation, and we sometimes tend to forget this study was relatively short, as you pointed out, only 1.8 years. That's a short time in the time of a patient with atrial fibrillation. Many of our patients receive therapy for 20 years. So in a way, if they had run the study longer, it may have actually been very impactful overall on both the number needed to treat as well as the absolute event rates. But having said that, another part that this points out is that 90% or so of patients actually do pretty well.
Yeah, this is very impressive, taking into account we are dealing with an epidemic in which we are afraid to give warfarin to the elderly, who are the ones getting atrial fibrillation. So, Adnan, you are an interventionalist using antithrombotic agents right and left.
Yeah.
What do you think?
No, I'm also very impressed by the results of this study, because it's very difficult from a study to expect reductions in everything. And this has been the case in this. You have said that the reductions are, in absolute numbers, not so impressive. But this is the way we are doing. Now the statistics is ensured not by the difference, but by the numbers. It will come the time that with one patient difference you will get a statistical difference if you go and enroll 100,000 patients. So that is true for all the recent studies that have been in the range of 20,000 patients. No surprise for that. I am impressed by the fact that this study showed in both directions reduction. Magnus said it. Both reduction in ischemic and bleeding complications. This is very rare phenomenon.
Yeah, and we'll talk about in a minute when we compare with the others. I think this is a very good point.
Yeah, and this has been the case when we replaced anticoagulation with double antiplatelet therapy. for the first time, because everyone is thinking if you are going to reduce ischemic complications, you are getting more bleeding. This has not been the case when we replaced anticoagulation with dual antiplatelet therapy. At the time, we reduced both bleeding and ischemic complications.
So it seems that we are moving in a field that a few years ago we thought we couldn't move any further.
So if you address exactly the mechanism, if you address the exact patient, if you have the exact dosing, you get this excellent result.
Silvia, you are doing electrophysiology. Why you don't get rid of these clots by closing the left atrium or just ablating the atrial fibrillation? I think this is a future too. Is not correct?
Well, I think that we are practicing the electrophysiology, trying to bring back the sinus rhythm in the patients, and using the ablation for that reason. But the anticoagulation still remain a key and the most important factor for the patient with atrial fibrillation. And I don't think that an alternative answer is so easy and around the corner. So this study seems to me very exciting because beside the benefit that you have outlined in the 3 different ways, but I still regard as impressive, there is also the fact that administration of warfarin is a burden for the patients for many reasons, checking the INR, controlling the concomitant therapies. So I think that for the atrial fibrillation patient, from the point of view of the arrhythmologist, the alternative to warfarin that are so effective will really change the way we practice.
Mariell, twice a day. Do you like that? Well, you're working in cardiac failure. You give 7 drugs twice a day.
7 drugs. We almost give 15
So for you,
drugs.
this is not impressive.
This is a piece of cake. And I think what's important to add to what everyone else has said is this study tells us we really are going to have to embrace these new anticoagulation drugs. And I think it's going to require a whole new review of our systems of care. I also think it brings out the point about learning the different kind of strokes, because ischemic strokes were not reduced. And it may be that we're going to have to understand a little bit more about prevention of ischemic strokes rather than hemorrhagic or thromboembolic strokes. So I think it is going to focus a little bit more on what are the different kinds of strokes. We can't lump them together anymore. And this turns out to be important in a lot of the antiplatelet drugs as well.
I think, though, as we face the elderly, the fact that hemorrhage is decreased, general and hemorrhagic stroke, is quite remarkable. And actually, this leads me to ask you, Terje, you are used to statistics and all the drugs you have used in prevention and so forth. And let me give you some data, see what you make of it. Let's compare the 3 drugs that have been used orally for other than warfarin for atrial fibrillation, and I give you the data. Now, if you use dabigatran at 150 milligrams twice a day in relation with warfarin, you decrease the stroke, but you increase the bleeding. Now, if you use dabigatran at a lower dose, you decrease the bleeding, but there is no difference in a stroke. If you use apixaban, actually you decrease the bleeding, and you decrease the stroke, and you decrease mortality. And if you use rivaroxaban, what you do is you decrease the bleeding, but there is no difference in a stroke. This is my question. Can I tell you that apixaban is better than the others, like an intermediate dose between the 2 dabigatrans? Or you think this is something that a poet can think about it and we have to face one against the other? Tell us what you think.
I think the most scary thing for patients who are taking warfarin or any anti-thrombotic drugs over a long time is the risk of hemorrhagic stroke. Intracranial bleeding is really the big scare. And in this trial, apixaban cut the rate of hemorrhagic stroke by half, which in itself is fantastic. It's a remarkable result. And for that reason only, I think apixaban is shown to be superior to anything else on the market.
I have a question for you, Magnus, and then I have a question for you, Bryan. This is my question to you. There are 3 studies done with apixaban recently, and it's difficult to pull them together. See if you give us an answer. The first one was apixaban with acute coronary syndromes, and the study was discontinued because of hemorrhage. Tell us what that means in terms of giving one drug in addition to clopidogrel and aspirin versus the drug alone.
Well, this goes almost back to your background, Valentin. Is it thrombin or is it the platelet? And I think with stents and all the things that Adnan and I do in the cath lab, we do away with lesions. But we have to have that dual antiplatelet therapy to be around. But I don't think there is enough room then to add a thrombin inhibitor. And our patients are really going into a very steady phase of their disease, just like they were before they had an event. So I think that we have to keep an eye on the stability of the patient. That is to say, in the coronary, is the plaque very unstable? Well, if it is very unstable, yes, there would potentially be some value of a thrombin, just like we do for acute ST elevation MI, preventing thrombin generation or working on the thrombin pathway. But once you're stabilized, I think it's more in the platelet realm, and therefore, the event rates are so low that the risk of bleeding as we add these agents go above it. But it is confusing because you have, on the one hand, an atrial fibrillation, and I would say maybe as much as half of the patient in the study actually had some coronary disease. And so therefore, how do you put this together?
We have to be careful.
Yes.
Be very cautious, and that is, we cannot use in a trial, everything are pure and perfect, but at the moment you deal with the patient with a stent, and then with atrial fibrillation, if we start giving a 10A inhibitor, can be a problem. This leads actually to you in the hypertensive field. When you face a patient with hypertension, you are giving one drug. You might increase the dose, or you may add drug after drug, and you don't have any problems with it. Tell me how you feel about this discussion, because you're in a field which is completely different. It seems you keep adding until you get the blood pressure normalized and no problem.
Well, our drugs are pretty safe relative to these drugs, but I think in the context of AF, we also see a lot of atrial fibrillation.
That's
because,
true.
It's almost the end stage event of diastolic fibrosis of the ventricle. We see an awful lot of patients with AF, and we have to make the difficult decision about anticoagulation. And we always err on the side of anticoagulating these people. But hemorrhagic stroke is a particular anxiety when you're anticoagulating people with atrial fibrillation and hypertension. And the thing that interests me about this study is that we talk about the fact that the main effect is on ischemic stroke, on hemorrhagic stroke. But in fact, we mustn't forget the fact that we are comparing 2 drugs and we're looking at the incremental changes. So actually, both drugs are almost certainly reducing embolic and ischemic stroke. And really the debate in anticoagulation, as I see it, is can we get to the point at which we optimize the reduction in ischemia without increasing the risk of hemorrhage? And what this study for me shows is that with this dose of this drug, we get at least as good a protection against ischemic events in a population at high risk of ischemia, but we minimize the risk of hemorrhagic events, particularly hemorrhagic stroke, which presumably drove the mortality benefit. And so for me, as working in hypertension, this is a good news story, because what I want to know is if I anticoagulate patients, the drug action and the dose, is that the right one for my patient that's going to minimize the risk of them having a cerebral hemorrhage? And it looks to me as though this is the best data that I've seen in the context of AF.
Well, this is excellent. So I'd like to finish the discussion about this fascinating study by asking each of you to define it in 2 words. I do not accept 3. Terje, you're the first.
Well,
No, 2 words. You are already talking too much.
I accept it.
Excuse me?
I accept the results.
A very promising result, encouraging for the use of this drug.
I would say win-win, safe and effective.
Changing the field.
Excellent study.
Game-changing.
I would call bleeding. Excellent. I think we are all in agreement this is a 5-star. Okay? Well, thank you very much. I think this is a good way to start. And now we go into HDL. Why HDL has been up and down, up and down, up and down? I still remember the last 30 years. You know, the same thing. And now when we thought everything was working, niacin goes to the pot. How is possible? Well, anyway, one of these days we'll see another miracle. And it's time to discuss such a possibility.
We just saw a miracle.
Excuse me?
We just saw a miracle with the first study.
Yeah, that's true. This will come.
Yes.
Okay. I hope soon. Anyway, let's maybe it's important to introduce the subject of the second study entitled dal-cetrapib in the so-called dal-VESSEL. Now, what is dal-VESSEL? Well, dal is because of dal-cetrapib, but this is actually one of 4 studies that are being launched with this particular drug. One is dal-VESSEL, we will discuss. The other will make a comment about dal-plaque. And then we'll make a comment about dal outcomes. And we'll make a comment about dal-plaque too. I think it's worth perhaps starting very briefly by giving a sense of HDL. And that is one of the aspects of HDL is that does many things, but certainly reverse transport is an important one. What is reverse transport? Is basically ApoA1 is manufactured in the liver. It goes into the macrophage of the vessel wall, takes the LDL. LCAT, which is an enzyme, makes this LDL with the ApoA1 to have a conglomerate, and here's where HDL comes in. And then it's destroyed by CETP. And then once it's destroyed, HDL and the rest go into the liver and then into the vial. And all aspects have been tried, but certainly the CETP is an interesting one because what you are doing is preventing the catabolism, I would say, the HDL, and therefore you raise it. And LDL can also be lowered. So this is the background from the aspects of HDL. Now, if we go historically, have been a very interesting 4 years. One was the drug was torcetrapib. As you recall, the results of the drug were spectacular, increasing HDL, but perhaps because of increasing blood pressure and alteration in the aldosterone system, the drug ended up being detrimental. And the second one that was anacetrapib, which we don't have a lot of data except that increases the HDL by almost 100%, and decreases the LDL very significantly, and there is no increase in blood pressure, and this is all what we know today. And now we are going to discuss the third one, which is dal-cetrapib, which is the one, dal-VESSEL, which is the one that was presented in this meeting. Well, this is a study that was presented by Dr. Lusher, involving 500 subjects who had an HDL less than 50 milligrams per deciliter. And they had coronary artery disease or coronary artery disease risk equivalent. And these patients actually received 600 milligrams of the drug actually versus placebo. What is surprising to me is the first endpoint, which is one of the aspects that actually HDL has been most controversial, which is vasodilatation. So one of the aspects of or endpoint in the on the drug was the flow-mediated dilatation of the brachial artery, And certainly the primary endpoint was safety, blood pressure, aldosterone, etc. Now, the results were interesting in the sense that when you look at the dose that was used with dalcetrapib, 600 milligrams daily, and the dose that was used previously with the other medication, anacetrapib, was quite different. There they used a dose, I think was about 10 or 20 milligrams. It was very, very low. Or maybe, it was 100 milligrams. But the results of HDL have been quite different. The one that here we use 600 milligrams, actually HDL certainly increased from an average of 39 milligrams to 48. This is not 100%, and the dose was much higher. And the same happened with the LDL. It decreased a little bit, but not to the extent that happened with the other drug. Now, the study made news, and it's interesting what is new in this study that we didn't learn with the previous drug, anacetrapib. Well, maybe it's an exciting area, and therefore we found there were no side effects, and they certainly maybe the dose is the right one. The HDL that goes up is different than the other one. So there are many questions that maybe we cannot compare one study with the other. But I like maybe to ask your opinion. I can maybe you, Terje, since you are in this area of LDL, HDL, maybe you can give us a sense how you view this study, your reaction.
I am not sure that flow-mediated dilatation is a measure of long-term development of atherosclerosis or not. Mm-hmm. There are rather conflicting data around that, and I think that I would rather have seen a study using IVUS or other imaging modalities rather than flow-mediated dilatation.
Yeah, we'll talk about this because it was presented actually by our group here.
Right.
And but I think you're quite correct. Vasodilation is not one of the endpoints that I think is an exciting one, particularly talking about HDL. What is your reaction, Magnus?
Non-plus. I thought it was an interesting study. 600 patients. It's not going to give me any comfort about the blood pressure response that was seen with the first line of agents. So I think it's an interesting physiological study, but we will need to see a lot more before we get excited about this one.
Mariell?
Well, being a heart failure doctor where we haven't had a lot of wins, I also see in managing patients raising HDL as sort of our last horizon. So we all want a drug. I think we've gotten really, it's a real possibility to lower HDL to target in most of our patients with safe drugs. But I think we all watch patients who have a low HDL and a low LDL, and so I think there's a great need for drugs that potentially can raise HDL. So this is a first step, and it didn't cause any harm. So I'm cautiously optimistic.
Terje, why the difference between both drugs? Do you think the HDL is different?
It's the mechanism of action of dalcetrapib and anacetrapib seems to be very different, and according to the producers of these drugs, they attack on a completely different mechanism. So the fact that dalcetrapib doesn't affect LDL cholesterol, whether that is important or not, on top of a potent statin, I wouldn't know. I think this field is very difficult. I can tell you a story. Mike Brown, the one half of Goldstein and Brown, who won the Nobel Prize for detecting everything about LDL cholesterol, He was once asked the question, Mike, now that you and you have discovered everything about LDL cholesterol, are you now going to embark on HDL? And Mike answered, no, HDL is too difficult for us.
Interesting.
So there are many, many secrets that we know nothing about behind HDL. And it's a very difficult particle.
Very interesting. Bryan, what do you think?
Well, I think it's interesting that you come to a big international conference, and in a plenary session, the story is we can give a drug that raises HDL and doesn't do any harm. We've got to the point where we're actually more concerned about whether we're going to do any harm as to whether we can actually detect benefit. And that to me is a bit of a worry. Now, in this study, they looked at blood pressure as a signal, and that was appropriate because of the rise in blood pressure in some patients with torcetrapib. So that's reassuring. I'm not so sure what FMD would have given as a signal, whether it would have been positive, negative, or otherwise. But at the moment, I remain a little confused as to where this field is going to go, and we desperately need outcome trials. Without outcome trials, I think it's very difficult to interpret whether this is good or bad in terms of particular drugs and the amount of elevation. It looks a weak effect compared to some of the other HDL modulating drugs, but maybe the type of HDL it modulates is better than the HDL modulated by one of the others, and it's such a confusing area.
One aspect that was interesting of the 4 different projects, the project dal-PLAC, it was presented by my colleague Tahi Fayyad. Basically, what a group of us did is to look at the plaque in a subset of these patients. And it's very interesting. It was presented here. First of all, the inflammation with positron emission tomography, it doesn't change. So one cannot say that HDL, the drug affecting HDL is anti-inflammatory. That's number one. But number two, the plaque very significantly decreases its progression with MRI. And we look at the large arteries. I think this is interesting. It's something subclinical, but at least it's telling you that perhaps there is something.
Well, it's a positive signal. Yeah.
It's a positive signal. Then there is another study which is dal-PLAC2, in which ultrasound is being used. Here what was used was positron emission tomography and MRI. So this is the other study ongoing. And then the final study that is interesting altogether is called the dal-HEART, as I mentioned, is the DAL outcomes with 15,000 patients recently hospitalized for acute coronary syndromes and trying to look at the outcomes. I'm not going to ask Terje because he's in the data monitoring committee of the trial, but I think that particular study is the one that is probably we have to wait rather than numbers and HDL going up or down. 2 words.
Not yet.
A good source of hope for larger studies.
Need more.
Remain uncertain.
Wait and see the next trial, the large one.
Agree.
I agree with everything. Agree all. Okay. Well, thank you. Certainly, the next study I think is going to be very interesting. The one addressing the outcomes. Well, I left a study for the end, but not because it's less important. In fact, I think it's a very important study. The so-called the PURE study. The title, as it appeared in the Lancet yesterday, was Use of Secondary Prevention Drugs for Cardiovascular Disease in the Community in High Income, Middle Income, and Low Income, a prospective epidemiological study. Basically, the study aimed to assess how people is treating secondary prevention. This is a large population. Actually, they were screened about 150,000 people, and over 5,000 had coronary artery disease, and about 2,000 had a stroke. And this is the group that was looked at, how much aspirin they are receiving, how much beta blocker they are receiving, how ACE inhibitor they are receiving, how much statin they are receiving, or they are receiving at all. And then they divided the communities in economically high, medium, low, very low economically, and that's basically what was done. And the results actually were quite striking, but not surprising to us, as I will tell you in a moment. When you look at the use of antiplatelet agents worldwide, this is a sample of the world, was 25% only of people who had coronary artery disease and a stroke. And you may say, well, I don't believe it. In the high income groups, 62%, in the low income, 8%. What is interesting is that aspirin is very cheap. And what could say, there's no question is the economics play a role here, but it's difficult to understand why aspirin is also part of that. So I guess you develop a culture, and then this is all beta blockers, 17%, ACE inhibitors, 19%, statins, 14%. Now let me give you the data that we found on a trial that we are running and is going to be published soon, which is the FREEDOM trial, not the trial in itself, but this is a trial of diabetic patients who have coronary disease, and in 150 institutions around the world. And we are obsessive about medical therapy. This studies diabetic patients with multivessel disease, stenting versus bypass, but we feel that probably the medical therapy in these groups is the most important aspect. So writing letters every week, results. Only 20% have their risk factor profile being addressed. And then you say, well, why you are so different than Courage and Barry, which were not different at all? I don't want now to say all the data, but we learn of this. Is a reality that perhaps is an alarm that we don't pay enough attention to. People are not taking the medications when they feel well. Well, this is what the study shows. And then what they found, very interesting, is that notice how poor is a person, but how poor is a country, or how rich is a country, they found. And then whether you are in an urban area or you are in a rural area, there are differences. So we have a problem of adherence across the world, and then we have a problem, certainly, of economics that they play a role. But I just wanted to present this to start. There are other things we are going to be discussing here, but I just wanted to at least get your reaction. It's very simple in the cath lab. When you see a patient that is going to take aspirin and clopidogrel, but you are in an interventional area, that intervention doesn't fail. Devices go there, and people are motivated. But here, that's the story. So what is your first reaction, Adnan, to this type of data?
Valentin, I'm not so surprised by this. I want to be a little bit provocative. It is like you are dividing the countries according to the income and looking after that whether there are differences in income in these groups, because this is obvious results. I would be more interested to see with what has to do this low rate of use for this or for the other drug, whether this is price specific or culture specific or system specific. These are more useful information. But to know just that there are differences between these groups of countries, it is not surprising for me.
The difference is not very significant. We look at the FREEDOM trial. And in fact, one of the things was to look at high income, middle income, low income. There is a difference, but is not very significant. In fact, let me give you the data. In high-income countries, about only 25% of people have all the risk factors being addressed.
Yeah.
Here's a different data. They go one by one but when you look at the data all, then you come up with the reality.
This is a good starting point to know what is the situation now, and to make changes in the system, and to see whether these changes are effective in changing this situation. This is a very good starting point. But for me, it's not so relevant to compare.
You are not excited?
I'm not excited, really.
What about you, Magnus?
Well, I hate to tell you this, but we have the same information in rural North Carolina. So, very rich country, yes. High debt, yes. But I think we have failed as an entity, and I think that's the more important part of this paper. We have failed to translate all the benefit that we have provided to patients in the level of education, that is to say, medical literacy, to understand why we are agitating about these things, because we have not reached the individual to the right level for this. I think compliance cost is a big issue, but you cannot make that argument, as you said, with aspirin. It's just not, doesn't compute. So we have a little bit here, I think, but we as a profession, and I think this has been shown in heart failure too, that we need to really help our patient understand why we are. So their medical literacy and understanding of what we are trying to accomplish is really key for success.
Silvia?
I think it might be something expected, anticipated, but it's still important because these patients, exactly because they belong to a country with less organized medical system and less resources, if they develop coronary artery disease, the mortality might be higher than the mortality that we have in Western countries or countries with richer possibility, treating the patient. So I think that is one point when I find it important. The second, I also think it's important that we start helping collecting epidemiological data in countries who do not do it themselves. They don't have resources. So for these two reasons, I think that the study has made me interested, and I think it deserves being discussed in this forum.
Bryan?
Yeah, I think it's very important. Actually, I think there's a perception of many people who've read this paper that it's about low-income countries. It's about our countries too. And, if you look at the, North America, European countries, we're not that much better in many of the aspects of secondary. And this is secondary prevention. So we haven't even gone into primary prevention, and Lord only knows how bad that might be if we looked at it. And I think it's a tragedy. I mean, we're at a meeting here looking at, high-tech interventions to get incremental benefits in people with established disease. We have incredibly low-cost, well-proven treatments that could make a massive impact worldwide. And actually, aspirin is cheap as a generic, but also many of the other drugs are now generic too. And I think what this paper will do is create the kind of discussion that's needed about why we cannot translate really high-quality science and production of very effective drugs into a mass policy, not only in developing countries, but also in our own countries. And so I think it is an important paper, and I think it is worth discussing.
There are several issues. Mariel, this morning we had a symposium, and actually I spoke after Yusuf, and my topic was the polypill in secondary prevention. And it's interesting because in the paper just came out in the New England Journal from Yusuf, in this pure study, says systematic approaches are needed to improve the long-term by use of basic, inexpensive, and effective drugs. And there is no question the polypill is extremely expensive to make it. Pharmacologically, it has to be perfect to go through the FDA and so forth. But certainly we are in 2 trials, and in our polypill is beginning to be already accepted in some low-income countries. And what is interesting is how inexpensive it is, because the problem with all the pills is the distribution, but not the single. However, in the discussion we had this morning, something came out, and that is, sure, we can give a polypill, but I think we have to do some kind of a mass education and the organization should be much more prone, the governments decreasing salt in the foods and all of that. I think that probably is part of the story. I'd like to hear your reaction to this, because it's a very interesting study that maybe is an alarm to some of us. Maybe we knew about it, but something has to be done.
I agree. I think it was an incredibly important way to start this meeting and to maybe give us a little stimulus to focus not only on secondary prevention for everyone, which has multiple reasons why it's poor, for access to care, to financial, to education, but to really start at the very young age for prevention. And I think it can happen. We need to encourage people to exercise. We need kids to pay attention to diet. And I feel strongly that it's a possibility that we've seen in our lifetimes. I mean, today's children all around the world know they have to buckle up and put their seatbelt on. And that's because we started with them when they were very young, and we emphasized it over and over again. There's no reason with sort of a nationwide, worldwide approach that we can't start simple messages and really spend some time on it. So I was delighted that they presented this early. I think it was a theme about finding people other than physicians to deliver care, which I think we need to start to think about in heart failure and in every other field, that we're going to have to recruit a whole new organization of people to deliver the good care that's needed.
Actually, I think Mariell made two comments which I think are quite interesting. She tends to move from prevention to promoting health in the way she spoke, and I think this is one aspect that I want to hear from you, because prevention has a negative connotation. Promoting health, I guess, is more positive. And the second issue that you mentioned, I have a lot of experience with this because we are dealing with 25,000 children in Colombia with Sesame Street, and what we are doing is exactly that, and that is between age 3 to 6 is the time to infuse, because that's the time they capture. But these two aspects that Mariell mentioned, I'd like you to comment on. You have been in the field of prevention for many, many years, and I believe that she's absolutely correct. Children and promoting health, and the question is how we do it.
I think that some countries in Northern Europe have been fairly successful in promoting health to children in schools. I think Norway has been fairly successful, and now they're removing soft drinks from being available to school children and promoting water instead, although there have been some setbacks. I agree with that. For example, the government tried to promote green recipes, recipes for health-promoting behavior, but it hasn't been extremely successful so far. So it's a difficult issue.
It's interesting because New York City, has been, when you talk about New York, everybody is overweight. You hear this all the time. But I must say Bloomberg had a tremendous impact by using like the seatbelt approach, that is obligatory things, the cessation of smoking, now working on the salt intake, working on the restaurants if they don't cook with the right oil. I think the issue of obligation is important. However, Bloomberg is the only mayor in the United States who has the capability to direct health by the bylaws of New York, and he's doing a good job, and certainly his colleagues. But I think we have to get into something from the top and using the seatbelt approach. Anyway, any other comment about this particular study?
Well, and I think the other thing that when I see this type of study, we say high, low, medium income, it doesn't reflect exactly what is going on, because within our society we have all those aspects. So in a way, it's an average of an average. I would like us to really focus on the Health Development Index, which actually takes into consideration not only income, but also education, because I think the educational part of what we have been doing has sort of lagged a little bit. And what you're doing in Colombia with the school children, I think is absolutely right. If you teach somebody at age 7 to 9 something, it'll be with them forever.
There must be some medical inertia here as well, because even in the developed countries where there's good access to healthcare and the drugs are available, you're still seeing very low rates of provision of very effective drugs. And one of the other things that comes out in the paper is that it's not just secondary prevention of coronary disease. The secondary prevention of stroke is even worse. I mean, you look at the stroke patients where we know that blood pressure and some of the other risk factors are hugely important in risk of restroke. That 20-30% of them people are being treated. It's extraordinary. So I think there are huge economic advantages to governments, and I agree with what you said, Valentina. This probably needs a shift from being medical policy to more towards political and social policy to try and get some of this.
And then who is doing the job in the firing line? I think we are used to talk about doctors. We are absolutely wrong. Doctors are very busy.
Maybe we're in the way.
And this should be the health system. Nurses or practitioners and so forth should get involved. And I think we all made the mistake. Yeah. This is something we have to spend the time doing it, and it's not happening.
Another point is that the study shows that the patients with hypertension were treated more than the patient without. And it was interpreted as saying that the doctors like to see something decreasing or something getting better after they give the therapy. So our mentality might be more to treat a disease rather than preventing a disease.
It's interesting, a number. This happened with cholesterol. In fact, I think the cholesterol, the figures, you have to be below such and such, is something that is attractive because it's simple. And maybe we are complicating things too much, and we should be much more simple. Well, anyway, we had 3 fascinating studies, the one on 10A inhibitors and atrial fibrillation. Then we had a significant, interesting discussion on the concept of HDL, and we hope in the future, as we said, will be a miracle. And finally, we became a little bit low, even in the tone of our voice, when we discussed the last study, the PURE study with the adherence to drugs and the economics. But I think the 3 are very interesting, and I would like perhaps to finish by asking you, Mariell, what do you take from these 3 studies? What it will be on you in saying, this was important, let me move forward?
Well, I have to say that I was really influenced greatly by the PURE study. I think it really, again, in the field of heart failure or any other field, we have to start to prevent and we have to deliver care equally. And so everything that I heard during the meeting and these big trials were, that's fine, but how do we get people educated? How do we make sure that drugs are available to them? So it colored everything else I did.
Well, Adnan, you were not too excited about that aspect.
No, but you are asking for about the 3 studies.
Yeah, but yeah. I'm saying that you're going to talk about.
So that's, you want to say I'm more impressed by the Aristotle, and I see a very good potential from this study for a challenging subset of patients we are treating every day with stents. Patients with atrial fibrillation who need triple therapy after drug-eluting stents, and might be apixaban might be a good solution for them, seeing that it reduced bleeding complications here. In combination, it didn't work in combination with the dual antiplatelet therapy for acute coronary syndrome, but the control was a placebo. Here, the control should be warfarin also. So I see a very good potential, even for us interventional cardiologists.
Okay, Magnus?
Well, if I can take a global view, I have to say what's fascinating to me this meeting, we're gradually going more realizing that we're dealing with chronic diseases. We talked here a few minutes ago about childhood. I mean, if we're really going to make an impact now that we've got stents, we've done all the high-tech stuff, the harder lifting now of getting prevention is that it is a much chronic, long-term educational piece, and maybe our systems are not set up well for it. But I do believe that we're heading into a very sort of chronic phase of heart disease that we need to take different approaches to improve our outcomes.
Good comment. Bryan?
Yeah, I think the Aristotle study is the one that I probably will go away thinking that is the most likely to change practice from what we've heard at this meeting. Because I think the safety aspects will, and the at least equivalent efficacy to alternatives must drive change in this area, and it'll be very price sensitive like it often is. But there's no doubt that this is a safer way of anticoagulating patients with atrial fibrillation. So I think that's an important message. The study with the CTP inhibitor hasn't really clarified anything regarding my uncertainty about the place of these drugs in future treatment. We desperately need the outcome trials that we've discussed. And lastly, the PURE study, using your style of saying in 2 words, I would say 3, and that is lost in translation. And that's a tragedy.
Good. Silvia?
I find it exciting that we are proving that the pipeline of new agents in cardiology is still alive and vibrant and giving excellent results as the Aristotles. I think that the concept that in cardiology we have sort of reached a plateau and maybe was not from a funding agency worthwhile investing in cardiology as other areas were in need for more, is actually showing that there is still a lot of concept like the HDL work that needs more research and more exploration. And finally, of course, that we need to implement, as you said, what we discover and what we prove with the trial. So that is something, sort of a background message that we should get out of the PURE.
Good. Terje?
I think that the apixaban study is going to change medical practice. I will not comment further on the dalcetrapib study because of my role in the development of that drug. I was not surprised by the PURE results, having seen how long time it takes to change medical practice in the affluent part of the world, as been shown by, for example, the Eurospire investigations on the use of, for example, statins in secondary prevention. It has taken 15 years since 4S, West of Scotland, CARE, lipid study. 15 years before now most people with acute myocardial infarction in Western Europe are being given statin. So it takes time. And in the developing world, we have to be a little patient, I think.
Okay, thank you. Well, we are at the end of this discussion. I can summarize by saying that this meeting was particularly stimulating in this regard. I think this discussion has been very stimulating. I must say that there was not enough controversy. Maybe we should have a few punches after we finish this. Okay, but it seems we in general we were all in agreement with what came out from these 3 studies, and certainly again I want to thank you all of you for being here, and I hope we will continue with these discussions, waiting for a few miracles as we discussed before. Thank you very much for your attention.